Hello students, welcome to term 3. This lecture recording will be the review of the concepts hormonal regulation, glucose regulation, and we will also begin to discuss the disease process of diabetes. You will learn the difference between type 1 and type 2 diabetes and also discuss some long-term and short-term complications. If you do have any questions, please refer to the readings that have been provided to you through your SurePath um, platform. So let's get started. So let's start at the Giddens concept where we talk about hormonal regulation. Hormonal regulation is important to us because it is what regulates the secretion of the hormones, in the case of diabetes, insulin and glucagon. And then it also is associated with the regulation of when these hormones are released. So we have a few key terms that we would want for you to know. So in your Giddens book, we have a definition for an endocrine gland, which is a specialized cluster of cells, tissue, or an organ that produces and secretes hormones directly into the bloodstream. Again, we are going to focus a little bit on the pancreas and how that organ works to help maintain glucose regulation. A hormone is a chemical substance that stimulates cellular action into target tissues. So for this, we will focus on insulin and glucagon. The target tissue is basically the specific place that the hormones are influencing. So here we are looking at moving the blood sugar from the bloodstream into the cells so that we have energy to function. The receptor site is the location on the surface of a cell where the hormone attaches. So when we talk about insulin, we say that its main purpose is to be the key, right, to unlock the cell so that glucose can get in. So if you can remember that, that is the purpose of your insulin, the key part, then you would always remember that if there's no insulin, no key, the energy can't get into the cell. So when we talk about negative feedback, a couple things that you need to think about. Okay, so you're teaching a patient about insulin regulation. So which statement best describes a negative feedback mechanism? I'll give you a few seconds to read through the answer choices. So when we talk about your answer choices, the one that makes the most sense for negative feedback would be the one that says B. Right? This is where your rising blood glucose will stimulate the insulin. So it'll say pancreas release some insulin, which helps lower the glucose levels. All right. So negative feedback works by counteracting a change that happens in the body. So when blood glucose rises, insulin is released to lower it. So once the glucose level gets back down to our regular levels, insulin secretion is reduced. This is how the body maintains homeostasis, all right? And on the other side, right, when the blood sugar goes really low, what happens is that the pancreas releases a hormone called glucagon, and that glucagon interacts with the liver to help release some of that stored glucose it has in there. Let's talk about the pancreas itself. So the pancreas is made up of many different parts. So this one here, it's called the islets of Langerhans, right? So these little islets have alpha cells and beta cells. And for the most part, what we're seeing is that from the alpha cells, the glucagon is released. So glucagon is the key, right, that allows the sugar back out of the cell. Or if you think about it, it's the key that actually goes to the liver and says, hey, move the glucose stores that you have, break it down, and put it back out into the cells. Beta cells, on the other side, is where insulin lives. So insulin is the key that allows that sugar to go into the cell. And if you think about what we talked about in lecture, right? Every insulin key is what's needed to open the cell so glucose can get in. Sometimes we have patients who have issues with insulin use, right? So it's not able to open the cell so blood sugar can get in. All right, so let's move on to the concept of glucose regulation. Okay, so in Giddens, she defines glucose regulation as basically the process of maintaining optimal blood sugar levels. This is very important because, you know, we store glucose in the muscles, we store glucose in some organs for future use. But one of the things that, one of the organs that doesn't store glucose is your brain. So if we have less than optimal blood sugar levels, our brain will not function appropriately. Okay. You're going to hear the word glycogen used. So glycogen is the stored form of glucose, and these typically live in liver and muscle cells. Okay. We talk about counter-regulatory hormones. So these counter-regulatory hormones oppose the actions of other hormones. So a counter-regulatory hormone to insulin would be glucagon. Another one that we see a lot of is cortisol, which is our stress hormone. So anytime your body is under stress, whether or not it be illness, lack of sleep, this is something that is released by the body so that it tends to elevate your blood glucose level, right? So you don't necessarily need to have diabetes to have a spike in your blood glucose. You could just be stressed out or fatigued. All right. When we talk about other things that are considered counter-regulatory hormones, we also talk about steroids, right? So a steroid is something released by your body. A corticosteroid is something released by your body that elevates your blood sugar. So if you were sick and you were prescribed prednisone, which is a steroid, that's going to raise your blood sugar because it acts upon, the body, and it increases that blood sugar just like it's were naturally forming in your body. Let's move on to a couple other ones. So insulin is the hormone that facilitates glucose metabolism. You're going to hear that all the time. You're going to hear about type 1 diabetics and how they need to have insulin all the time. We're going to talk about type 2 diabetics and the occasional need for them to have insulin to control their blood sugars, right? Insulin resistant is a state in which the body's cells respond abnormally to insulin. So this is where when you're picturing insulin as a key to the cells, you're going to see that insulin, right, will go up to the cell, and the key may or may not fit on that cell wall. So this is what that insulin resistance is. You have insulin that's being produced, but the insulin isn't being metabolized or utilized like it should. Like the key doesn't really fit the lock. So sometimes in an insulin resistant state, we have some insulin that can work and some insulin that doesn't work. So you have to kind of figure out which key opens the lock when we have an insulin resistant state. That's why we have medications, right, that help the body utilize this insulin like it should. One of the words that you're going to see, kind of long. So Giddens defines this gluconeogenesis as the process of breaking down something else, not carbohydrate based, for energy. So this occurs when the body's blood sugar gets so elevated, and it's like, I know I have energy floating around and available to me, but I can't get it. So then it starts to utilize something else for energy. Typically, it goes towards your fat stores, the protein stores in your body, and it starts to break it down. So we see a lot of this happening in times when you're like fasting, or if you have what we call diabetic ketoacidosis, right? The insulin isn't available to move the blood sugars in the bloodstream, right, to the cell. So then it basically starts to break down something else for energy so that the body keeps running. Right. Next, we're going to talk about some risk factors that are going to impact glucose regulation. Okay, so there might be a couple things that you will notice, right? Impaired glucose regulation can occur in any individual. So basically, that means that you and me are at risk for having either really high blood sugar or really low blood sugar because one, we skipped breakfast. So that would indicate that probably 3 hours from now, we're going to start getting those symptoms of hypoglycemia. Or you might have been rushing off to school, you grabbed an energy drink. The only thing you could find is a Pop Tart to eat on the way. So you drank your energy drink and you were eating a Pop Tart. And by the time you got to school, you weren't feeling so great because now your blood sugar is probably 300. Okay, so anyone can have impaired glucose regulation. But in this case, we look at some higher risk populations. So one of them being pregnant women. All right, so pregnant women have a high risk of having some sort of glucose regulation issue because when when in pregnancy we get hormonal changes, right? And these hormonal changes can produce a state of insulin resistance. So that's why at about 24 weeks we are having mom go in, get their 24 to 28 weeks, I believe, is when they have mom go in, have that glucose tolerance test done so that we can treat mom accordingly if she has what we call gestational diabetes. Okay. The only reason we worry about that is because, when somebody has diabetes, it tends to speed up the way cells divide. So it tends to lend itself to larger than gestational age babies. So it's not uncommon for them to be born at about 10 pounds. And then, of course, we talk about infants being affected. So when infants are born to a mom that has gestational diabetes or has diabetes altogether, right? They typically end up being larger, but after birth, um, they tend to run the risk of having hypoglycemia. So it's very important that you know mom's medical history because you need to anticipate for hypoglycemia for that newborn after they are born. Okay, they might need more feedings so that we can keep their blood sugars elevated. In older adults, what happens is that we have an increase in visceral fats, which means fats that kind of line around our organs, right? So we see a decrease in muscle mass. So this increases the risk for our older adults to have hyperglycemia. Okay. Oftentimes, these patients are going to have oral medications plus insulin therapy. We do have a few racial and ethnic groups that are at risk. More incidences are seen in like our Native Americans, the Alaskan Natives, our African Americans, Asian Americans, Hispanic, Latino descent. Typically more of a type 2 um, issue with our Northern European people of descent. They run a higher risk of having type 1 diabetes. Okay. Of course, we talk about individual risk factors. So basically, we can kind of group people into a population. But, if you're not in any one of those populations or you don't fall into that, there are individual risk factors that will put you at risk, right? A family history. So if your grandma had diabetes, your mom and two aunts had diabetes, the likelihood of you getting diabetes is elevated. So it's very important that somebody go to the doctor yearly to have that checked so we can catch it early. All right. So family history, obesity, that obesity increases your risk for insulin resistance, right? Any type of lifestyle, typically the more sedentary the lifestyle, the more increased risk we are to insulin resistance. So a lot of time our diet plays a big role. And so if you don't eat very well and then you don't exercise or you don't move a whole lot, that increases the amount of like cholesterols in our blood, and of course increases the visceral fats that lend itself to insulin resistant. Okay. Some chronic conditions can increase our risks. So sometimes even a diabetic, right? Diabetic is a chronic condition. So medical risk factors like metabolic syndrome. So diabetes, you can either have high blood sugar, or if you take your insulin and you forget to eat, you get low blood sugar. And then, of course, we talk about medications. So some common medications that will have an impact in your glucose regulation would be insulin, right? Your oral diabetic medications, and some steroids. Okay, so those are some medications that are the most common that we're going to see. We're going to talk about them in a little bit. So let's talk about some more common things that you're going to see, right? For somebody to have a glucose regulation issue, they're either going to have a blood sugar that is greater than 110 or less than 70. Okay, so when we talk about some common things that we see. All right. Hyperglycemia is one of them. So when we talk about hyperglycemia, it is a condition where the blood sugar is elevated, high blood sugar, right? Um, we know that this can be caused from insufficient insulin production. So in our type 1 diabetics, they don't make any insulin. So their blood sugar is definitely going to be elevated. Or in our type 2 diabetics, you're going to have hyperglycemia because they make insulin, but the body doesn't know what to do with that insulin, right? We have that state of insulin resistance. Or in a type 2 diabetic, you have that state where they're producing insulin. It's just not enough to help bring down the blood sugar that is floating around in the bloodstream. We also talk about that deficient hormone signaling, which is your insulin resistance. We talk about excessive counter-regulatory hormone secretion. So this can happen if you're sick. It can happen if you're stressed out. It can happen if you have an injury. It can happen when you're, you know, you just are sleep deprived. So excessive counter-regulatory hormone equals higher than normal blood sugars. It's not going to say that it's going to be there all the time, right? So we just need to make sure that if we have a patient that is on prednisone, which is a steroid, right? We need to make sure we're monitoring or checking their blood sugars so that if it does get to the point where it's too elevated and it's not coming back down, you're seeing, you are treating that patient, okay? Sometimes you're going to get patients that are like, why do you keep checking my blood sugar? I'm not diabetic. And you can just explain to them that it is because of their medication. So let's think about some signs and symptoms that you're going to see with hyperglycemia. So I want you to pause, take a moment to think about it. I'll give you about like 20 seconds to list some signs and symptoms of hyperglycemia, and then we'll go over it on the next slide. So with hyperglycemia, what you need to think about is like, what am I going to see when I have high blood sugar? So typically we have polyuria, polydipsia, polyphagia. So make sure you know the three P's are the classic signs, right? Increased urination, increased thirst, increased hunger. All right. But it's not, remember I told you, it's not important that you memorize it. What's important is you know why it happens, right? So when we talk about polyuria, it's because we have something called osmotic diuresis happening in the body, where your patient is, the kidneys are like, hey, let me help you out. Let me get the blood sugar out of the bloodstream because apparently we're not going to use it and it can't get into the cells. Because we have this increase in urination, it tends to trigger the thirst mechanism. So because now we're feeling a little bit dehydrated, so the body is like, hey, I'm thirsty, drink more fluids. So with increased thirst, right, increased drinking equals more urination because you're trying to get more of that fluid out. Tends to lend itself to dehydration. Okay. You get hungry because your body is like, hey, I need energy. So it signals that hunger receptor. And so when the body starts eating more, unfortunately, we don't have insulin, right? Or we don't have enough insulin to bring down that blood sugar. That blood sugar gets higher. Okay, so if you remember this mnemonic flushed, right? Or if you remember the saying, hot and dry, your patient's sugar is high, that means you need to treat that blood sugar. Okay. Some of the symptoms on here, like, hyperventilation or Kussmaul's respiration. So it's a rapid, deep type of breathing, not like shallow breathing, but deep breathing, because that is compensation for acidosis when they are in DKA. Okay. And also, that fruity odor on their breath, it smells more like acetone to me, like nail polish remover than it does fruit, but that's how you describe it. That would be the signal that somebody is producing ketones and starting to burn the fats and proteins because there's not enough carbohydrate for energy. Okay. Let's talk about hypoglycemia. So hypo rhymes with low, so you should know that hypoglycemia is any blood sugar less than 70, right? Less than normal, or it can be any symptoms of the following, right? So remember, we don't just treat numbers, we treat symptoms. So your patient could have a blood sugar of 95 and still have these signs and symptoms that they're not feeling well. So you need to do some further investigation. Don't just be like, oh, their blood sugar is 95, they're fine. We need to treat that symptom. Okay. So some things that can occur is that your patient didn't eat enough, right? Or they're malnourished. So not enough food intake, prolonged starvation, malnutrition, typically lends itself to life-threatening hypoglycemia. Okay. Some adverse reactions to medications. So your patient took or you gave too much insulin, or your patient took too much insulin and they didn't eat enough of their meal. They kind of got full. Or they, took their insulin too early. Okay. Um, Too much exercise can lead to hypoglycemia. So glucose is stored in our muscle as glycogen, right? Just like it's stored in our liver. So when you're exercising, if you don't like eat a snack before you exercise, the body starts to break down that glycogen in the muscle cells and it uses it for energy while you're working out. That's why marathon runners have to fuel while they're running, right? They got to take in some carbohydrate. They use those glucose gels. They might eat gummy bears and fruit snacks while they're running because they need some quick energy to help them continue so that they can finish that 26.2 miles, right? Stores get depleted during exercise. Sometimes after exercise, you need to replenish the muscle of that glucose store. So you need to, eat some quick carbs like a banana or a piece of fruit. Drink some Gatorade, get some of that sugar back in. You could probably even drink like soda, helps get the sugar back into the system. Okay. Um, that prevents the body from going into a lag effect where it gets really tired and you need a nap to kind of re-energize the body. Okay, so I want you guys to, just like we did with hyperglycemia, list some symptoms of hypoglycemia. So if you're one of those people that are like, man, I get them confused, then do a table. Put hyperglycemia on one side, put hypoglycemia on the other. Okay, give you a couple seconds to do that. Right, so with this, always remember that with low blood sugar, it's going to affect our brain function because remember, our brain doesn't store blood sugar. Okay, so when we talk about hypoglycemia, you're going to see things like, I'm tired, low energy, I'm sleepy, um, uh, their level of consciousness goes down. They get more and more confused, right? They get tachycardic. They get irritable. They get hungry. Remember, hunger happens in both type in hyperglycemia and hypoglycemia. Okay, so that's one of the symptoms that happens in both. Blurry vision also happens in both hyper and hypoglycemia, right? Because it impairs your vision a little bit. So make sure you know these signs and symptoms. The more common ones that we see, you feel like your heart is racing, get a little bit shaky. Sometimes you start to get really sweaty. You might get lightheaded, right? You might get a headache, get anxious, or suddenly feel really tired. Okay. Just remember that with hypoglycemia, this is more of a priority than hyperglycemia because the lower the blood sugar gets, we tend to end up with like seizures and coma. So your outcome for someone with low blood sugar is more of a priority, right? A little bit more of a priority than someone who's got elevated blood sugars that are still alert and talking. Okay. All right. Let's talk about some lab tests that we're going to see. All right. So more commonly, there's some testing that you'll see, and in your Giddens book, they talk about it as to like what the most common ones that we're going to see. So blood glucose testing is used for screening and also monitoring of how well your body metabolizes the glucose. So basically looking at how well your body uses the insulin it has available. So there's a couple things that we look at. So we do something called a fasting blood glucose, right? A fasting blood glucose is basically when you go into the lab and they take your blood sugar. You haven't eaten anything for 8 hours, right? And that's what your blood sugar is when you get up in the morning. So I always think about glucose tests, random blood glucose, a fasting blood glucose. Those are things that are telling you what your blood sugar level is right now. Okay. A glucose tolerance test is one of the more sensitive indicators of how well your body metabolizes sugar. All right. So this is where you go to the lab, you've been fasting for 8 hours, they take your blood, they take a random blood glucose, they give you the syrup to drink, and then you wait at least 1 to 2 hours to just kind of see whether or not your body is metabolizing that sugar like it should. All right. It can be used to detect early diabetes. So if your doctor is like, oh, your blood sugars have been running 150 every time you come into the office, let's go send you for the glucose tolerance test, right? They could probably figure out whether or not you are diabetic. Um, Most recently now they do the hemoglobin A1C, or the glycosylated hemoglobin. All right, so it can be both on your test. It's reflective of the average glucose reading over a 3-month period, right? Used for diagnostic screening and monitoring of your disease process. So if you were someone whose blood sugars have been 150 fasting and you go to the doctor's office and they take a hemoglobin A1C, they can do that just like they do a blood sugar, and your A1C is 8.2. That means that over the last 3 months, your blood sugars have been elevated. And so now we may need to treat, right? Or we may need to suggest diet and exercise to see if we can bring that down. So any number, hemoglobin A1C greater than 6.5, indicates that you are diabetic. Okay. Once you are diabetic, the doctor's goal for controlling your hemoglobin A1C is typically less than 7%. All right, so that indicates that you have very good glucose control if you can bring that number to less than or equal to 7%. Okay. Another thing that we talk about is, antibody testing. So antibody testing is used to confirm whether or not the person has type 1 diabetes. All right, so for type 1 diabetes, remember, we talk about it being an autoimmune process. So it being an autoimmune process, if I drew blood and looked for certain antibodies, it should result in the bloodstream, right? That would confirm that your patient is a type 1 diabetic. All right. Most common one that they look for is a glutamic acid decarboxylase, the GAD test. So they only do this for a patient that they suspect is a type 1 diabetic, right? Another one that we look at is called the C-peptide test. So according to Giddens, the C-peptide test is the indirect measure of insulin levels in your bloodstream. All right. And it's used to measure residual insulin production. So if a patient with type 1 diabetes had a C-peptide test drawn, we know that a type 1 diabetic doesn't make insulin, so they should not have any residual insulin in their blood, because there's none being made by the pancreas. On the other spectrum, we can do a C-peptide test on a type 2 diabetic, and we can see that there might be some residual insulin in the bloodstream that isn't being used, because those are the keys that didn't fit any of the cells, right? So that would indicate that your patient might have some insulin resistance because there's still residual insulin available in the bloodstream. So we can use the C-peptide test for both type 1 or type 2 diabetics. Okay. Some other important ones that we're going to use is the lipid analysis test. So this is your lipid panel. Includes the measurement of your total cholesterol, which we want less than 200, your HDL, which is recommended at greater than 40. The higher the HDL, that is your good cholesterol, right? I always indicate HDL, you want high, right? The H and H. Your LDL is the bad cholesterol, so you want that lower. So typically less than 70. So if you can be like L is for low, you want that lower. That is your bad cholesterol. Okay. And then we use triglycerides. So there is a correlation between high triglyceride levels and high glucose levels. So the higher that triglyceride level is, it corresponds to that glucose being elevated. Okay, so in a perfect world, you want higher HDL to control that LDL and triglyceride level. Okay, HDL can actually tell you the severity of your patient's insulin resistance. So if you have lower HDL, you're going to have higher triglyceride and LDL levels, which means your patient is most likely insulin resistant. All right. And then, of course, we'll talk about complications, one of them being, kidney issues. So renal functions tests are important to measure how well your kidneys are functioning, especially in our diabetics. Okay. So they look at measuring BUN and creatinine. Make sure you know the levels for BUN and creatinine. So BUN 10 to 20, creatinine 0.6 to 1.2. Just make sure you know those numbers. And of course, anytime your patient comes into the doctor's office, they might do some urinalysis, right? And on the urinalysis, they're checking for a couple things. They're checking for glucose in the urine. They're checking for protein in the urine. They're checking for maybe some ketones, right? Because if there is a sign of protein loss in the urine, it could indicate renal damage, right? So the earlier we catch it, the more chance we have to protect or preserve the functioning of the kidneys. And then, of course, there's one last one. It's not on your screen. It's called the C-reactive protein test. So we know that in times of insulin resistance, right, we look at inflammation. Um, C-reactive protein is produced during times where we have increased stress. So if it's elevated, it typically indicates that your patient has or is in a metabolic syndrome state. Basically, it's probably some other risk factors grouped up into one. So if your C-reactive protein is elevated, right, might signal that your patient might have some insulin resistance going on and also an increase in cardiovascular risk. Right. So let's go on to this figure. So in Giddens, I want you guys to familiarize yourself with these concepts. Okay, so Giddens' book is full of concepts, and it's actually one that is very relatable. So when we talk about concept, I want you to see the bigger picture. So I'm going to explain to you what's happening with all these bubbles. Okay, so when we talk about glucose regulation, right, we say here is glucose regulation in the middle, right here, glucose regulation. Glucose regulation has a close relationship with hormonal regulation because what do we need to maintain glucose? We need to have insulin and we need to have glucagon, right? That negative feedback loop that that controls the blood sugars. So glucose regulation and hormonal regulation are best friends. Okay. In order to control glucose regulation, we talk about nutrition and exercise being important, right? So nutrition and exercise are needed for optimal regulation, and they're also needed so that we can manage the likelihood for complications. So we talk about complications being, our acute complications like DKA and hypoglycemia, or it could be long-term complications. So if our blood sugars are elevated over a long period of time, you're going to get like kidney issues, neuropathy, wounds, infections, those type of things. So we definitely need to have optimal nutrition and mobility, right, to help control glucose regulation, right? Down here at the bottom, and I'm going to highlight it, is your complications that you are going to see right here. These are the complications that are going to happen if you don't control your glucose levels when you have diabetes. So we say with perfusion, right? We tend to have micro and macrovascular issues. So macrovascular would be your big vessels, right? Could lead to strokes, heart disease, those type of things. We also say that tissue integrity is affected, so poor wound healing. If you do get a wound, it's very slow, right? Could be because of blood flow down to those areas. Could be because your, the blood sugar, right, the blood is too sweet and it hinders the healing of the tissue. Okay. We talk about elimination being affected. That is your renal function. So we'll talk about renal function, tissue integrity, immunity later on in the term. Okay. You should have a basis of knowledge on these. Your patient will have an impaired immune function. We talk about changes in vision and feeling when you have sensory perception issues and diabetes, right? Remember, we talked about one of the complications being retinopathy, right? That has to do with their eyes, and also peripheral neuropathy, right? That is your sensory perception issue. Over here where it says adherence, culture, and family dynamics, that is very important because it influences the behavioral changes needed for optimal health. So if somebody has been diagnosed as a type 2 diabetic, right? And we say that you need to exercise more, change your diet just a little bit. They might not see it as, oh, that doesn't relate to me. I'm still going to eat fried chicken. I'm going to eat macaroni and cheese. I will eat my greens that are prepared with a ham hock. I'm going to use a lot of salt, right? So those cultures or family dynamics play a big role in adherence, right? Like how many times am I going to check my blood sugar? You might only check it once. You might not check it at all because you don't want to stick your fingers. They hurt, right? So that plays a big role in glucose regulation. And then, of course, here in the corner, we talk about patient education. Patient education is the cornerstone of our treatment, right? We teach our patients how to check their blood sugars. We teach them all about their diet. We teach them about how exercise affects their blood sugars. We teach them about their sick day protocol. We teach them about their medication. So it's all about teaching our patient so that we can have good blood sugar control. Okay. Hope nobody has any questions. If you do, you can refer to your Giddens for further reading. But as the term goes along, you're going to see that diabetes is one of the risk factors for many of the disease processes that we're going to talk about. Okay. Any questions on that? Because if not, we're going to move on to our next portion of the slides. Okay. So let me go on. So let's talk about diabetes. So here's a little snapshot from your osmosis. I'm hoping you watched those osmosis videos. So basically, the definition of diabetes is that the body has trouble moving glucose, right, from the blood into the cells, which results in a state of hyperglycemia. Okay, so when you have a state of hyperglycemia, your body, the pancreas, should produce insulin, right? So when we talk about diabetes, right, so the word diabetes means urine, sweet urine, okay? The term diabetes describes a group of characteristics where you have chronic hyperglycemia, so chronic high blood sugar, and an issue with metabolizing carbohydrate, fat, and protein, right? We'll talk a little bit more about that later. But per the CDC, right, it estimates that about 38.4 million people in the United States have been diagnosed with diabetes, either type 1 or type 2. Right, so that's about 11.5% of the population. Okay, there are about 8 million people walking around undiagnosed with diabetes. Those are more of our chronic long-term complication people. Okay. People with diabetes tend to be at risk for a lot of things because high blood sugars, right, play a role in, how fast these complications develop. So what we want is to have our patients screened, right, so that we can diagnose them early, so that we can have better management of their blood sugars, so that we prevent complications. We'll talk a little bit about the complications in the next few slides. So let's do a comparison. So one of the key features of diabetes is hyperglycemia, which is elevated blood glucose. So just remember that type 1, type 2, and gestational diabetes, elevated blood glucose. Okay. Type 1 diabetes characterized by the absence of endogenous insulin, which means your pancreas is not making any insulin to help move those blood sugars. Okay. We talk about our type 2 diabetics. They make a little bit of insulin, but the body doesn't know what to do with that insulin, right? Or they have a state of insulin resistance. So basically, the body makes the insulin, but not all the insulin makes it to the cells, right? And you have the wrong key to the cell, so it doesn't work. We talk about gestational diabetes. So gestational diabetes is diagnosed when a woman is found to have a glucose intolerance, typically at any point during her pregnancy. Once mom has given birth, this should resolve, right? But it increases mom's risk for having type 2 diabetes further on down the line, right? It's a hormonal thing that changes the way the body responds to the insulin being produced. That's why we check mom early on in their pregnancies. So type 1 diabetes has been attributed to a genetic issue, could be an immune issue, could be an environmental factor. Okay, so the tendency towards type 1 diabetes is typically found in families with a genetic predisposition. We used to call this juvenile onset diabetes because it's found mostly occurring in, people under the age of 25. But we've also found that it can occur in middle age and older adults in people who have lost the functioning of their pancreas. So they become very dependent on their insulins from the outside. Okay, so that's why now they're just calling it type 1 diabetes. For these people, we think it's more of an autoimmune process because they've found autoantibodies in most of the people that have developed type 1 diabetes. All right. So in type 1 diabetes, there's typically a destruction of the pancreatic beta cells that produce this insulin, which results in a total insulin deficiency. Right. Patients with type 1 diabetes, typically, if it's a genetic predisposition and they're exposed to an event, let's say they got the flu, it's typically that viral infection that lends itself to that autoimmune response and the destruction of those beta cells, right? So these people require insulin for the rest of their life. So they have to give it to them in insulin shots, or they have to administer it, through the insulin pump. There's not another option. So when we talk about type 2 diabetes, right, this is somebody who makes insulin, but it's either inadequate or the body doesn't know how to use that insulin. All right. So we talk about the beta cells responding inadequately to that hyperglycemia. So what's happening is that, your body is signaling that the blood sugar is high. The the pancreas releases the insulin, and then what happens is that the insulin then only half of it is being used. So over time, the pancreas is like, well, you're only using half the insulin that I'm making. So I'm going to back off production of the insulin to preserve myself. And after a while, your body kind of gets used to that chronic state of high glucose, right? It desensitizes those beta cells. They become less responsive to that. Your body then adjusts itself to that. So this is typically found more common in our older adults. So anyone over the age of 35 tends to get diagnosed with type 2 diabetes because of that insulin resistance. We talk about children getting this, especially children who have been found to be obese. They tend to have more of a type 2 diabetic with the insulin resistance. All right. Some patients can be treated with oral medications and insulin to help normalize the blood glucose first, but usually we encourage diet and exercise before insulin use, right? Because it has been found that if somebody does lose some weight and they eat regularly, they cut out a lot of the carbohydrate based diets, you can control the blood sugars just through diet and exercise, and they might not ever require medication. Let's move on to our clinical manifestations. So, anybody with diabetes, their first and foremost clinical manifestations are typically the three P's, right? Polyuria, polydipsia, and polyphagia. That occurs anytime someone's blood sugar is high. So make sure you as a student know what polyuria, polydipsia, and polyphagia is in common layman terms. So increased thirst, increased urination, increased hunger. In type 1 diabetes, basically, we have the three P's. So I explained to you earlier about how the polyuria occurs, right? The blood becomes thick with glucose, which increases the osmolality of the blood. And because of this thickness of the blood, right, the urine starts to increase the production of urine. And then, of course, because the blood is thick and too sweet, we want to also, kind of muddle it down so it stimulates the thirst center, causing the thirst center to to signal that you are really thirsty. Okay, so increased urine production, increased thirst, increased hunger. That's when you have that person who's like, I need more energy. Please eat more food because I need carbohydrates that go into the cells. All right. When you have a patient, especially type 1, I want you guys to know that this is something that manifests pretty quickly. So type 1 diabetics, it's a rapid acute onset, right? They're going to have the three P's. They're also going to have weight loss because their body is metabolizing fats and proteins for energy. Okay, so they're going to lose weight. So indicatively, when they first get diagnosed with type 1 diabetes, these patients would have lost like 10 pounds, right, in a short amount of time. You're going to hear that, they've been more hungry lately, but they've lost weight. They've been more thirsty, they've been urinating more. That should, in your brain, trigger that something is wrong. Okay, that their blood sugar might be elevated. Unexplained fatigue happens because there's no energy going into the cells, so they are going to feel like really tired. Okay, diabetic ketoacidosis is one of the complications that can happen to these patients that have type 1 diabetes. We talk about type 2 diabetes. This is more of a slower onset, right? During the early stages of the disease, your patient might not even realize that they are diabetic. They probably won't have a lot of symptoms, or as the body kind of gets used to being in an environment where the blood sugar is really thick or the blood sugar is elevated, it resolves itself. Okay, so they can complain of symptoms later associated with the three P's, right? The polyuria, polydipsia usually, and polyphagia. They may or may not lose a little bit of weight. It's not going to be as evident as your type 1 diabetics. Okay. These patients usually don't come in and seek medical care until they have some sort of a complication. It could be that their vision is blurry, or it could be that they have a wound, right? And that wound hasn't healed in a couple weeks and now it looks a little bit more infected. Those are typically when these patients come in to seek some assistance. So unless this patient is going to the doctor every year, they may not even realize that their blood sugars are elevated. So these patients, the ones that live with their blood sugars being as high as 300s, right, they will feel some sort of hypoglycemia if we start to bring them down to what we consider normal. So that's why I say, right, don't treat the numbers, treat the symptoms, because your patient's blood sugar might be like 150, but they're shaky and they're diaphoretic. You might need to check their blood sugar because their body is used to living in an environment where the blood sugar was like 250, 300s. Okay. All right, so let's talk about some risk factors. So in type 1 diabetes, the risk factors are typically pointed towards more of a genetic predisposition, right? Um, there is a We don't know if there is a non-genetic risk factor for type 1 diabetes, unless, your patient had pancreatic cancer. That's probably a risk factor. But type 2 diabetes, they have very many well-established risk factors, right? In your readings, right? The National Institute of Diabetes and Digestive and Kidney Disease identifies the biggest risk being obesity and sedentary lifestyle. That alone can lead or contribute to insulin resistance, right? Another thing that can increase the risk for type 2 diabetes could be a family history. You could have a history of gestational diabetes. You fall in line with one of those ethnic backgrounds, right? Alaskan, American, Native American, um, African American, Hawaiian, Pacific Islander, Asian American. Okay. We talk about some things that might increase the risk. So, um, sometimes you get polycystic ovary syndrome, PCOS, and that has shown that there could be some signs of insulin resistance that can happen. All right. One of the signs that you're going to see is this right here. It's called acanthosis nigricans. It's basically like a thickened, like pigmentation of skin, usually found in the groin area, on the back of the neck, or in the axillary area. If you see something like this and the patient is not a diabetic, that is an indication that they might have some insulin resistance happening. Okay, so you might want to notify a provider or even just check their blood sugar, just to kind of confirm your suspicions. But that is one of the signs that you're going to see for insulin resistance. Metabolic syndrome is another thing or risk factor, and it's basically a cluster of metabolic abnormalities that significantly increases the risk for a couple disease processes, right? One of them being type 2 diabetes and the other being cardiovascular disease. So you might have heard it as insulin resistant syndrome. Sometimes they call it syndrome X. So these patients typically have impaired glucose tolerance, elevated serum insulin, um, hypertension, high triglycerides, low HDLs, high LDL levels, which increase the risk for them having plaque buildup in their system. Okay. Um, your textbook describes metabolic syndrome as a chronic low-grade inflammatory process that basically can lead to vascular damage, right? And over time, it can result in some cardiac issues um, and also a progression of like your blood sugars going into type 2 diabetes. So it increases the chance of that insulin resistance um, going into type 2 diabetes. All right. So definitely need to make sure that our patients are going to the doctors, having their yearly checkups, because the faster we can identify the issue, right? The faster we do some lifestyle modifications, we can slow down or even prevent disease progression into either our cardiovascular issues or our diabetic issues. Right. Let's talk about some complications that you're going to see. We're going to talk about some chronic complications first, and then we'll finish up with our acute complications. So let's start with just a little bit of a chart, right? This is basically what you're going to see when we have these micro and macro vascular complications. If you see the three that we're looking at, retinopathy, neuropathy, and nephropathy, so those will be some of the symptoms that you're going to see with those microvascular complications. And then, of course, we're talking about macrovascular complications and like the results of what happens to our bigger blood vessels. Okay. So let's talk about microvascular complications. So these occur in both our type 1 and type 2 diabetes, and usually it results from the thickening of the basement membrane of the capillaries, right? That's where we have the exchange between nutrients and waste. So if we have kind of a backup in that system, you're not going to clear the waste, so it tends to damage that vessel and lead to more complications. So the most vulnerable areas for our type 2 diabetics and our type 1 diabetics are at the eyes, right, where you can have some vision changes happen pretty rapidly, and the kidneys, right? About 80% of our diabetics have kidney issues. Macrovascular complications, right, is when our blood sugars, if we don't control them very well, kind of play a role in either the buildup of plaque from high cholesterols or the stiffening of the arteries and veins in our body. So when we talk about macrovascular complications, you're looking at like coronary artery disease, our patients having strokes, peripheral vascular disease, and we'll talk more about those in the coming weeks. Okay, so we're not going to kind of get into it here with our macrovascular complications. Just know that if your patient has what we call metabolic syndrome, right, that central obesity, high cholesterol, high blood pressures, insulin resistance, that is going to increase your patient's risk for macrovascular complications. Does happen in both type 1 and type 2, right? More commonly, it will present itself in our type 2 diabetics because of the fact that it might take a little bit longer to diagnose those patients, right? We tend to diagnose our type 1 diabetics at an earlier age so we can teach them how to prevent those complications by having good blood glucose control. Let's start with diabetic retinopathy. Okay, so diabetic retinopathy is used to describe the pathological changes in the retina that are typically associated with diabetes mellitus. Okay. When we talk about retinopathy, it is the leading cause of blindness in adults. There are two types. We talk about proliferative retinopathy, which is your early stage. Typically, it's just the small vessels leaking and swelling. So when you go to the eye doctor and they dilate your eyes or they take a picture of your eye, that's what they're looking for, right? We're looking to see if there's a clue as to whether or not your blood supply to the retina is healthy. Okay, proliferative retinopathy is pretty much an advanced stage, right? So you have vessels that kind of grow, kind of like to help feed the retina so that you can see a little bit better, but they can bleed more, so it increases that risk, right? What we do see is we want to make sure that they go to those eye doctors every year so that we can catch those changes early. All right. Once your patient has changes or there's a change in their prescription, or the doctor sees something on the retina, they might have to go more frequently, usually every 6 months, just to make sure that the vision has stabilized. Okay, but yearly eye exams are required for all patients who are diabetic so we can catch complications. Right. So neuropathy is when we have kidney issue, right? So 36% of people diagnosed with diabetes also have chronic kidney disease. The way we talk about neuropathy is that, or nephropathy, kidney issues, is that because you have one, hypertension, and two, poor control of that blood sugar, right? The blood sugar tends to weaken or stiffen the vessels that provide the kidneys with a blood supply. So we'll talk more about kidney issues in week 6, or actually week 5 now. But just know that if there is an increase in our kidney function labs, right, or your patient starts to slow down on the urine production, that could be indicative of your patient having kidney issues. Right, so just know that retinopathy, nephropathy are two of the more chronic complications that we're going to see in our patients. We talk about making sure that we have early detection and treatment, right? So just like all of the other complications, we just want to make sure that if our patients have diabetes and we diagnose them at an older age, we teach them a lot more about controlling their blood sugars and maintaining hydration so that they don't get too dehydrated. If they are diagnosed as a type 2 diabetic, that is one of the labs that we will monitor closely just to make sure that there wasn't any kidney damage done during the time when they weren't diagnosed as a diabetic. Okay. Diabetic neuropathy is a nerve damage caused by long-term poor blood glucose control, decreased blood supply to the nerves, and chemical changes in nerve cells. It is very common. About half of the people with diabetes develop some form of neuropathy. All right. 30% of adults over 40 have reduced sensation in their feet, which greatly increase the risk for injury, infection, and amputation. That is why we do a lot of foot care teaching with these patients who have neuropathy. Okay. When we talk about neuropathy, There are three main types that you need to recognize. All right, so we start with mononeuropathy, which affects single nerves and can cause sudden sharp pain, often due to poor blood flow. Right? Polyneuropathy is the most common type and usually affects both feet or legs equally. Patients tend to report tingling, numbness, burning, or a loss of sensation with pain that is often worse at night. Because protective sensation may be lost, your patients might need to go to the podiatrist yearly to get their foot examined. But it is very important that they check their feet daily so that they can prevent any types of complications. We have something called autonomic neuropathy, which affects autonomic bodily functions, right? Which leads to problems like orthostatic hypotension, abnormal heart rate, gastroparesis, and urinary retention. Diabetic amyotrophy causes severe pain and muscle wasting in the hips and thighs and often interferes with sleep and mobility. So make sure you know the four different categories that are listed in your in your med surg book. Okay. Um, we talk about foot complications. So people with diabetes often develop foot complications because of neuropathy or poor blood supply or both, right? When neuropathy is present but circulation is good, the foot may look warm and pink with good pulses, but oftentimes your patient can't feel the pain. Okay, that's dangerous because injuries can occur without the patient realizing it. That's why we have them check their feet daily. That's why we have them wear shoes, right? So they have to wear socks and good fitting shoes. When blood supply is poor but sensation is intact, the foot may feel cold, pulses may be weak or absent, and the color changes occur. Um, so some of the changes you're going to see, right? The foot may be pale when elevated. That would be an arterial issue. The foot may be red when lowered. That is a venous problem. Poor circulation slows healing and increases your patient's risk for infection. Um, Foot ulcers often develop from minor injuries such as rubbing from tight shoes, cutting toenails wrong, shaving calluses improperly. Sometimes it can occur from burns because of heating pads and hot surfaces or the water is too hot, or they could have some sort of foot injury from chemical irritation. So there are over-the-counter medications that can remove calluses and corns. We tell our patients that if they do have those abnormalities, they need to go see the podiatrist. Okay. Patients who cannot see or feel their feet may miss early warning signs. So like a callus being inflamed, or they stub their toe and they don't realize that there's a blood blister there, or they can't feel that they caused some injury or opened up the skin. So we need to make sure they are checking their feet, right? With poor circulation, those injuries can progress to an abscess, an ulcer, or even amputation. All right. About 60% of non-traumatic amputations are related to diabetes. Treatment is difficult once ulcers form. Prevention is the most important intervention. So as a nurse, you need to teach your patients about daily foot care, wearing proper footwear, making sure that they are checking their feet daily, and reporting any changes that they find early. So when we talk about prevention of long-term complications, make sure you are looking at the box on page 1004 in your med surg book, okay? So the best way to prevent long-term complication is to control blood sugar. And of course, that can be done through diet, exercise, and taking their medications appropriately. All right. Target labs include hemoglobin A1C. Remember that if your patient is diabetic, the target number for the hemoglobin A1C is less than or equal to 7%. Okay. Make sure you also know the numbers for our triglyceride levels, LDL levels, and HDL levels. Those are very important in our patients who are type 2 diabetic, right? Don't really worry about it in our type 1 diabetic patients. Right. Let's go on to our acute complications. So when we talk about acute complications, one of the ones that we look at is hypoglycemia, right? Can occur if the patient who uses insulin or oral anti-diabetic medications. So you could have taken too much insulin, you didn't eat enough of your meal, you skipped a meal, or you exercised too much, right? That's acute hypoglycemia. If you do have a patient that is on insulin therapy and they have to exercise, they need to make sure that they're not exercising during the peak when that insulin is working its best. We talk about some signs and symptoms of acute hypoglycemia. So this picture is from from an osmosis, right? Signs and symptoms tend to appear first are shakiness, irritability, nervousness, lightheadedness, hunger, and sweating. So if you look at this slide, you can see that those symptoms are right here the top. So those are your what's going on, right? The brain is having less sugar to the brain. So you're getting some of the fight or flight response thing. All right. So due to lack of glucose to the brain, then blurred vision, drowsiness, slurred speech, disorientation, seizures, and unconsciousness could happen. So we have some early symptoms and then we have some later symptoms. Okay. When we talk about hypoglycemia, if your patient is conscious and able to swallow, then we use the 15-15 rule, right? 15 grams of quick acting carbohydrate. 15 minutes later, we're going to check that blood glucose level after you've administered carbohydrate. So we want to repeat that every 15 minutes until the blood glucose has one, gotten over 80, or two, your patient no longer feels symptoms. Okay, remember, it's always about treating symptoms, not just the number. If your patient is on insulin, right, we can do the 15-15-15 rule, but you need to make sure that they always have, some rescue like glucagon available. Okay, because sometimes insulin, because it lasts longer or it has a peak, and when it's at its peak, right, it might be another 30 minutes, depending on how much insulin you give them, as to how long we're going to, how much treatment we're going to give our patient. Okay, so glucagon is always necessary to have if your patient is on insulin. If they're at the hospital, we give D50, right? That's something an RN would administer because we can't give that IV push. If a patient is unable to swallow or they're too lethargic, too confused, can't follow directions, then you should administer glucagon, right? So one of the things that we say, right, when the sugar is all gone, give glucagon. It is basically one of the medications that we give for severe hypoglycemia. All right. The action of glucagon is just like how it works hormonally in the body. It breaks down your stored glycogen in the liver and converts it to glucose. And then, of course, the glucose goes to the body to help elevate the blood sugar. Okay, be careful because it does cause nausea and vomiting in your patient. So kind of if they're kind of lethargic or not really responsive, you might want to position them so that they do not have, or they don't throw up on you, or they don't aspirate if they do vomit. Okay. All right, one of the things that we're going to talk about is diabetic ketoacidosis. You see up on the top of the slide, it does say that you need to review in your reading page 1005. Okay, so diabetic ketoacidosis, or we call it DKA, occurs when there's not enough insulin in the body. So this usually occurs in our patients that have type 1 diabetes. Okay. Without insulin, glucose can't enter into the cells. So even though there's blood glucose for energy, right, the cells are starving for energy. Okay. With that, kidney tries to remove the excess glucose, which tends to pull water and electrolytes out, which then causes a large amount of urine and dehydration. Okay. Because glucose can't be used, the body starts to break down fat and protein for energy. And when fat and protein are broken down, the byproduct of that is ketones. Okay, so ketones are very acidic, and as they build up, the bloodstream becomes acidic. So they get into that state of metabolic acidosis. And this is considered an emergency because metabolic acidosis, if it becomes too high, right, can be fatal. Okay. Protein breakdown causes a loss of muscle mass. So if you see a lot of our type 1 diabetics, they are, for the most part, very skinny, they lack some muscle mass because a lot of times when their blood sugars get too elevated and they're out of control, they utilize fats and proteins. So they don't necessarily have a fat store in their body. Okay. DK in patients with type 1 diabetes, DKA typically occurs if they skip an insulin dose or during the times of illness and stress. That's why we teach them about their sick day protocol. Early symptoms of DKA include fatigue, headache, and a loss of appetite. Okay. Oftentimes, DKA is one of those presenters when your patient has been healthy and all of the sudden, something's wrong with their pancreas. This is when they find out that they have diabetes, your type 1 diabetics. Okay. They present to the ER with no history of diabetes, and this is their initial symptoms. As DKA progresses, right, patients develop those classic hyperglycemia symptoms, your 3Ps, and if left untreated, right, dehydration worsens, patient might have abdominal pain, nausea, vomiting, the fruity odor on their breath, and Kussmaul's respirations. Right. In severe cases, it can lead to coma, shock, and death, but it's not because of the blood sugar, it's because of that metabolic acidosis state. Okay. So when you're looking at labs, you're going to find a very high blood glucose level, typically greater than 300. 250 is like the lowest threshold to where their body starts producing ketones. So we have them watch those blood glucose levels. All right. Most often, they will have ketones in their urine or their blood. And of course, their ABGs are going to show acidosis, right? So remember acidosis, low pH, low bicarbonate level, all right? When we talk about treatment, right? Treatment for diabetic ketoacidosis is geared towards fluid replacements first, okay? So we look at fixing 3 major problems. So in your book, it talks about treating dehydration, right? So dehydration happens because our patients are urinating a large volume of fluid out of the body. So dehydration and of course an electrolyte imbalance and acidosis. So we begin with fluid replacement. All right. It's to restore the circulation. It's to help the kidneys clear the glucose. It's to help kind of restore the volume. All right. Insulin therapy is needed to start correcting the acidosis, right? We have to give it slowly over time. So it's going to be IV insulin, right? In the form of an insulin drip. So us as LPNs, we cannot manage an insulin drip. We cannot administer insulin via IV. But, you still need to know that insulin is one of the priority treatments for DKA. All right. So it needs to be given slowly so that the body can start utilizing the blood sugars for energy so that it can reverse the process of breaking down the fats and the proteins. Right. Insulin therapy will continue until that metabolic acidosis has fully resolved. Doctors utilize the anion gap on the basic metabolic panel to indicate whether or not that metabolic acidosis is fully resolved. We're not going to do ABGs every 6 hours on a patient because it actually hurts the patient when we do that. Okay. Um, Fluids are going to be continued to be replaced, and sometimes you might need to switch the IV fluids to something with sugar. So when you learn in IV therapy class those different fluids, right? We start with normal saline. Once the blood sugar gets to about 250, they switch it over to something with dextrose so that we can continue to support that blood sugar while we're giving that insulin. Okay. Plus, it helps manage the fluids, help manage the dehydration. We're also giving the cells some hydration in the process. Okay. You need to monitor the potassium level closely because when your patient is in acidosis, they're going to have elevated potassium levels, right? Once we start insulin and fluids, the potassium level can drop pretty quickly. So you need to make sure that your patient is on a heart monitor so that we can see changes in their heart rhythms, and they're going to we're going to need to check their potassium levels kind of frequently. So usually about every 4 hours. Sometimes at the beginning it's every 2 hours. Okay. Because we want to make sure that we're replacing that potassium level so that we can continue that insulin therapy to stop the breakdown of the fatty acids and the proteins. Okay. We're monitoring the patient neurological status because severe hyperglycemia and acidosis can affect the brain function. So they could start off as confused, lethargic, have decreased level of consciousness. And as we are treating our patients, they might become more alert, right? More oriented. They're able to talk to you a little bit more. But because of fluid shifts during the treatment, we might also cause something called cerebral edema. And we'll talk more about that in week 3. So it's very important that you monitor your patient's neurological status because we want to make sure that if a complication arises, right, and we need to report that to the physician or the RN that's working with us. All right. Looking at electrolyte imbalances, that's something that can happen while we're treating our patients. So some of these electrolyte imbalances, especially sodium and potassium, can cause an alteration in mental status, right? Plus, because we're giving our patient insulin through the IV, your patient might have hypoglycemia as a reaction. So making sure that our neurostatus, right, if we're doing blood sugar checks, you should also be doing neurostatus checks because one of the signs of hypoglycemia, right, is that change in your level of consciousness, change in your patient's cognition. Okay, so we're basically monitoring neurostatus to make sure that your patient isn't having any further complications. Right. One of the last complications that you're going to see is HHNS, hyperosmolar hyperglycemic non-ketotic syndrome. All right, very serious complication of diabetes, especially type 2 diabetes, because their blood glucose level becomes extremely high, often above 600. Okay, but because your type 2 diabetics produce insulin, right, your patient is not going to produce any ketones, right? So that's what's different between HHNS and DKA, right? HHNS, that non-ketotic, so this is the key word, is the non-ketotic, is they don't make any ketones, right? The pancreas produces just enough insulin to stop the fat breakdown and the ketone formation, but it doesn't produce enough insulin to control the blood sugar, okay? Because of the very high glucose levels, your patients will develop severe dehydration, which contributes to a high mortality rate. All right. Most of the time, we don't catch the dehydration or the very high blood sugars. So the mortality rate is about 15% higher than those of people with DKA. Okay. Some patients who don't know they have diabetes, HHNS, could be the first sign of the disease, okay, especially in our older adults. So just like our patients, this is something that occurs acutely. You remember I've told you guys the story about my patient who came up to the nurse's station and just complained of blurry vision and asked us to call the doctor because he couldn't see. And we just happened to check his blood sugar, and we sent him out to the hospital because our glucometer couldn't read it. And when they called us back, he was not a diabetic to begin with, right? So they called us and told us that his blood sugar was over 1,000. I think it was 1060. So that was his first sign and symptom of really high blood glucose. Was not a diabetic before that, right? He got diagnosed as a type 2 diabetic. Um, I think he was 72 was when he got diagnosed. So pretty older adult. In HHNS, persistent hyperglycemia causes that osmotic diuresis, which means that the glucose pulls water and electrolytes into the urine, and that's what leads to the severe dehydration and high sodium levels. All right, so to maintain balance, fluid shifts from inside the cells, go to the bloodstream, which further worsens the dehydration. So if you think about it, that's why it's called that it's like that hyperosmolar state where you need to have some hydration. So it pulls the fluid out of the cell. Okay. And so it further, one, you're dehydrating the body and you're dehydrating the cells. Okay. Neurological symptoms such as confusion, lethargy, or even coma are often more severe in HHNS and DKA. Unlike DKA, your patients with HHNS, they won't have nausea, vomiting, or Kussmaul's respirations, right? Because they don't have that ketoacidosis. They will tolerate the polydipsia and polyuria for weeks before they even go to seek care. So treatment is, for the most part, the same as DKA. We put a bigger focus on rehydration first, right? And we do insulin therapy, but we don't need to treat acidosis. So basically, we use insulin to help just bring down that blood sugar in a controlled fashion. All right. Our older adults need to be monitored closely during fluid replacement because sometimes they run the risk of fluid overload and heart failure because we're trying to rehydrate them really fast. Okay. So let's compare the two types of diabetes that we talked about. You're going to need to kind of know the differences so that you can kind of look for treatments and making sure we're providing good care. So our type 1 diabetes results from autoimmune destruction of the pancreatic beta cells, which leads to an absolute insulin deficiency, right? These patients are going to need to take insulin for life and are at risk for DKA, diabetic ketoacidosis. Your type 2 diabetics, their problem is caused by an insulin resistance and relative insulin deficiency. It is more common, often develops later in life, and is strongly linked to lifestyle factors. And these patients are more likely to develop HHNS. Now, for our complications, we look at acute versus chronic, right? Acute complications develop quickly and can be life-threatening. They often require immediate intervention, whereas chronic complications develop slowly over time due to long-term high blood sugar and vascular damage. So the key to that is to have good glucose control. They need routine screening. We do a lot of good patient education. Those are the key interventions that prevent our long-term damage.